Hello, friends. Welcome to our instruction course. I first thank Dr. Minu Mathan for giving me this opportunity to talk about how we manage posterior polar cataracts. So managing posterior polar is always very tricky because many of the time they all look like posterior polars, but they're not maybe really posterior polar cataracts. So whenever we see an onion ball-like appearance like this, we suspect that they may have dehiscence and complex surgeries, but many of them may not have. So the challenges are there is a high risk for PCR because of the fragility of the capsule and the adherence of the opacity to the capsule. So even at the last stages, you can have dehiscence. And additionally, there are surgical challenges because sometimes they may have very soft or sometimes they may have a very hard nucleus. And nucleus rotation may not be safe. So you may have to do a phaco without rotating the nucleus. And the other important challenge is many of these patients are visually disabled at a very young age. So they are in their productive lifetime. So you have to be very careful in doing surgery without any complication. So I would like to say PPC like this: planning the procedure and preparing the patient, telling them the risk, preventing a PCR or if possible a lens drop, and choosing the appropriate technique. There is a very dense cataract. I prefer to do a small incision cataract surgery than even a phaco in some of these posterior polar cataracts. It's very important to talk to the patients before surgery. You have to do that. It may take longer than normal surgery. The possibility of a nucleus drop, planning a secondary IOL later, any vitreoretinal interventions if there is a nucleus drop, and also if there is fibrosis, the possibility of doing a YAG laser a little later. And many of the times these young patients may have amblyopia also, preferably a peribulbar or a retrobulbar, or even subtenons anesthesia. We routinely do subtenons now. So where we do subtenons is anybody where we have seen a dehiscence on anterior segment OCT or on a slit lamp, or if the PPC is greater than 4 millimeters. If it is less than and we don't see any dehiscence on ASOCT, then we prefer a topical anesthesia. When you're doing a phaco, I think it's good to do the side port incision, gentle decompression done before making the main port, and avoid over pressurizing the anterior chamber at any stage, and try to use a heavy viscoelastic, especially in young patients, to counteract the scleral elasticity. Preferably a large rhexis because sometimes, following a dissection or a delineation, it can prolapse outside into the anterior chamber and make your surgery easier. Or if you want to manually prolapse also, you need a slightly bigger rhexis. But at the same time, you should have an adequate rim so that you can do a sulcus fixation of intraocular lens. Hydro is always a dilemma, because you cannot do a hydrodissection. But hydrodelineation is ideal, but very careful hydrodelineation should be done because by chance you cannot hydrodissect, and also avoid a vigorous decompression of the capsular bag. And definitely you should avoid any rotation of the nucleus. So this is a technique which was described by our own Dr. Abhay Vasavada. It's a brilliant technique. I do that as a routine to many of my patients. So I do this nice trenching and then do an inside out delineation. So you have to do it from inside after you have trenched the central part from either side. So this really helps you to make sure you do only a delineation and there is no fluid doing and cortical cleaving hydrodissection. And make sure your parameters are always slow. You have to do a slow motion phaco here. Multiple techniques described by a lot of people. Depending upon your experience and things, for a soft cataract, you can do aspiration. For a harder one, you can go for phaco chop, but without much rotation. So this is a nice technique, again, reported by our own surgeon, Dr. Rasak Vajpayee. It's a beautiful technique where you do a layer by layer phaco. So here you can see in this case, there is a nice posterior polar, and of course, already a dehiscence is visible. So adequate rhexis, not small, not big, is done. And then absolutely no any hydro procedure is being done. If you're just trying to do layer by layer. So you can see all these parameters are now aimed for a slow motion phaco. Then I'm using a Sinskey hook to first gently emulsify the central nucleus. So I'm just dragging to the center and then gently emulsifying it. And before coming out, we have to make sure the chamber doesn't collapse at every stage, especially when you see a dehiscence. And then next stage, we are trying to remove the epinucleus. So this is ideally done with a bimanual, so that you have a control over your fluidics. So you have to keep the fluid away from the dehiscence area so that you don't have any entry of fluid into the vitreous. So whenever you're coming out, it's to make sure that your chamber is reformed with viscoelastic when you change hands like this. And then you do this layer by layer phacoemulsification. First the nucleus, then the epinucleus, and then finally cortex. So definitely by doing this, you can't prevent a PCR because it's already there, but you can prevent the extension and also any drop of nuclear material, like in this case. So whenever you have dehiscence or a possible dehiscence, epinucleus and cortex removal is very critical. You have to lower the bottle height, try to pull the cortex tangentially. And even sometimes you can do a dry technique of syringe stripping, which helps, really helps. And you keep the central area attached till the last stage and avoid any kind of polishing of the capsule. The opacity removal, if it is there, it's good. You can try to remove, or you can do a primary posterior capsular excision sometimes, or you can leave it for an yard laser to be done at a later stage. In case if you have a PC tear, like what I said before, the remaining nucleus, if you have a big chunk of nucleus, you may have to convert to small incision, or you have to change to slow motion parameters. And if you are confident, you can remove the rest of the nucleus. So vitrectomy, as usual, in any case, how you do an anterior vitrectomy. IOL implantation, use a cohesive viscoelastic, avoid the IOL or instruments pressing on the posterior capsule. Preferably, you use a 3-piece lens. If your dehiscence is small, not extended, you can still use an Acrisoft single piece, which has got a very good memory so that you have a controlled release in the bag. Otherwise, you go for a 3-piece intraocular lens. Here, I'm just quickly showing you 2 scenarios where there is a dehiscence here, but we know the extent of the dehiscence, which is not extending to the equator. We have a controlled release of the Acrisoft lens. The memory of this lens really helps you. It doesn't unfold very quickly, so you can gently push it into the bag, and then without enlarging the capsular opening, you can implant the lens. But if you have a big opening like this, and it is also running to on either side, I think it's best you go for a 3-piece lens. 3-piece lens in the sulcus and an optic capture would really work. So ideally, people who have lost touch in using a 3-piece lens should practice once in a while. To do this, even in a wet lab practice will help you. Here I'm using a side port irrigation just to avoid a lot of viscoelastic there. And then the lens, one of the haptic goes to the sulcus, and then you rotate the rest of the lens into the sulcus. So this needs a little bit of practice, but it's a nice technique to do. And then you capture the optic into the capsular opening. So again, I would like to thank Dr. Minu for giving me this opportunity. Thank you.